All right, hello everyone, welcome back. We are going to start into chapter 14 now, which is patient monitoring, local and regional anesthetics. So without further ado, here we go. So first we're going to start out with some patient monitoring. The first thing we're going to talk about is electrocardiography, also known as the ECG. This assesses the patient's heart rate and rhythm. It's a process of recording the electrical impulses of the heart. So electrodes are placed on the skin and they're attached to leads that are attached to the ECG device. Electrical activity of the heart is recorded and displayed on a screen, and it's set with audible signals so that you can hear that heart rate and rhythm, that beeping that you often hear in the ORs. That is what we are listening to, is that heart rate and rhythm. They may be recorded with either a 3 or a 5 lead system. I will tell you that most commonly I have seen the 5 lead system. In that system, a lead is placed on each shoulder, each hip, and the 5th intercostal space on the left side. So you're right in between the hip and the axilla on the left side of the patient. And it's important as a surgical tech, and with time, you will learn to kind of discern between the different sounds and the varying speeds of the beeps, and you'll kind of learn to distinguish between what's normal, what's not. Is it getting higher? Is it getting slower? And even that dreaded asystole sound, you will learn to discern all of those. All right, pulse oximetry is a non-invasive measure of the oxygen saturation of the blood. It's usually done with a 2-sided probe that goes on either a finger, a toe, or an earlobe. And then with that probe, there is red and infrared light that will go through the tissues to the other side and measure that O2 sat. The ideal saturation level is above 95%. And readings can be affected by administration of dyes such as methylene blue. Vasoconstriction caused by hypothermia can also affect those readings. And there is a signal tone to this as well that reflects the changes in saturation. So along with that heart rhythm tone, which is going to be a timed tone, you will also hear it get deeper for lower sats or higher for higher saturation. So you'll learn to kind of differentiate and keep all of those in your mind. All right, going on to blood pressure. This is the measure of the force of blood against vessel walls. It's typically measured at the brachial artery. For an accurate reading, we need to make sure that the cuff fits properly, meaning that it's long enough to cover the circumference of the patient's arm, plus about 40%. We want about 40% overlapping on that cuff. The width of the cuff also needs to be appropriate. If it's too narrow, we're going to get a high reading. If it's too wide, we're going to get a low reading. A normal blood pressure in an adult is anything less than 120 for our systolic and less than 80 for our diastolic. Though those numbers and ranges are kind of changing as research goes on. People are living longer, obesity rates are changing, so those numbers are kind of under a microscope right now. They're kind of trying to reevaluate those. And then always need to make sure, whenever possible, that the cuff is placed on the arm without the IV catheter. All right, moving on to temperature. All surgical patients we've established before are at the risk for hypothermia. Okay, they're in very little clothing with those surgical gowns, and it's very cold in the operating room. It may be assessed from skin, bladder, axilla, ear, and esophagus. A baseline temperature is obtained when the patient enters the room, and then they're monitored throughout the case. Hypothermia is associated with a higher risk of surgical site infections, along with other things, so we do take precautions to maintain that patient's body temperature, either with warm blankets or bear hugger warming units, which are blankets that go over the patient. There's a hose that's attached to them that feeds warm air into it, several different ways. All right, capnometry is the measure of the CO2 that's exhaled by the patient. It's often called end-tidal CO2. In general anesthesia, an adapter is connected to the breathing circuit, and then a small piece of tubing will extend from that adapter to the analyzer in the machine. Sedated patients are monitored with an O2 cannula in their nose, and then an O2 mask, and then a small carbon dioxide sampling line can be laid just underneath that mask or right next to that nasal cannula, and that will measure their CO2 as well. It is vital that we monitor this for early detection of problems, such as esophageal intubation, where they've intubated the esophagus rather than the larynx. It does happen a lot. Compromised ventilation, and of course our good friend MH. Right, for monitoring consciousness of the patient, patient awareness under anesthesia is very, very rare. Okay, usually about 1 to 2 patients out of every 1,000. But it's still a significant concern. It's still something that we keep an eye on constantly. So an electroencephalograph, or an EEG, may be used to monitor the electrical activity of the brain. It's obtained from a sensor that can be placed on the patient's forehead. The monitor will display a reading between 0 and 100. Numbers near 100 indicate the patient's fully awake and responsive. And any number between 45 to 60, that usually indicates our appropriate depth, our ideal depth of general anesthesia, to where they are not aware of what's going on. All right, neuromuscular function. Muscle relaxants are administered to facilitate intubation and surgical site relaxation. A lot of times during surgery, you may hear your surgeon say he or she is fighting me a little bit. And what they mean is that their muscles are not relaxed enough, so they're tensing up as we're trying to make incision or manipulate a limb. So nerve stimulators are used to assess the neuromuscular function and the extent of any kind of blockades that we've given, which we will talk about in a little bit. So there are 4 stimuli, it's abbreviated TOF, the train of 4, are administered, and the extent of the block is estimated based on a twitch response. So we have these neuromuscular stimulators. It's almost like putting your tongue to a battery. So they have little metal probes. They do not hurt. They're just balls. We put them on either their face or at their hands, at the wrist, next to those nerves. And when you fire them, it makes your nerves twitch. 4 twitches would be 0 relaxation, and a 0 twitch would be complete relaxation. So that is what they're looking for. It's usually placed at the ulnar nerve or a branch of the facial nerve. So you will see anesthesia use these a lot when we are at the end of the procedure and we're waking the patient up. They will use these to monitor kind of where they're at in their anesthetic level. Okay, for some advanced monitoring, we have the arterial catheterization and pressure monitoring, also called an ART line. It's usually placed in the radial artery, and it's to record continuous, immediate, and highly accurate blood pressures. They're usually indicated for potential for rapid changes in blood pressure, frequent arterial blood gas sampling, or when blood pressure measurements are inaccurate. Okay, then we have the central venous pressure line, or a CVP line. This is positioned in the superior vena cava. It assesses the volume of blood returning to the heart, and it also assesses the need for fluids or to prevent fluid overload. Okay, the PA, or pulmonary artery Swan-Ganz catheter. It's guided through the heart into a branch of the pulmonary artery to obtain measurement of central venous pressure. PA pressure, pulmonary capillary wedge pressure, and cardiac output. It's a lot. Most commonly used during cardiac surgery and lung and liver transplants. So during heart surgery, we may also use a transesophageal echocardiography, or a TEE, and this is used to assess cardiac function. The probe is placed into the esophagus, and high-frequency sound waves are emitted through the tissues to accomplish this. So now we're going to move into some sedation and monitor anesthesia care, you will hear monitored anesthesia care most often referred to as MAC. Okay, MAC, MAC. So the ASA has defined MAC as a specific anesthesia surface for diagnostic or therapeutic procedure that includes all aspects of anesthesia care before, during, and after the procedure. It may include varying levels of sedation, analgesia, which remember is our pain control, and anxiolysis, which is a very relaxed but awake patient. So think of this as our anti-anxieties. Okay, levels range from minimal sedation to general anesthesia. And the indications include nature of the procedure, the patient's clinical condition or potential need to convert to general or regional anesthesia. MAC procedures include colonoscopies and EGDs. And the meds include Versed, Sublimase, Aflenta, Demerol, and Diprivan. All right, moving on to our local anesthesia. So this is a parenteral administration of anesthetic to nerve endings that are in the immediate surgical site, injected into tissue or applied topically to mucosal membranes. These interfere with sensory nerve endings on the operative area, and they do not transmit pain impulses to the brain. So the RN also in some instances may be able to monitor the patients without an anesthesiologist present, but it is under very specific patient guidelines. Age, health, physical status, varying different comorbidities, but it can be done to where the RN is the only one in the room with the surgeon and the tech. We will normally refer to those as straight local cases. All right, there are a few different applications for local anesthesia. The method of choice for several procedures has it may be used without sedation. Common applications for local with MAC include breast biopsies, transvenous pacemaker insertions, venous access port, or catheter insertion, or the placement of a dialysis graft. And there's a few different ways that we can do this, so we'll go through those too. Tumescent anesthesia is widely used for liposuction. It involves a large volume of dilute solution into subcutaneous tissues, and that facilitates the back suctioning while providing local anesthesia and reduced blood loss. Commonly contains usually about a 0.5 to 0.1% lidocaine, and epi 0.5 to 1.5, and normal saline. Okay, there are a few different agents that are used for local anesthetic. They are chemically classified into two groups. They are the amino esters or the aminomaids. Please read Insight 14.1. That is on the pharmacokinetics of local anesthesia. The first local anesthesia agents were topical cocaine and injectable Novocaine. Cocaine is still used today in nasal surgery, though not as often with the development of some other drugs. But please remember that cocaine should never be injected. It is for topical use only. Okay, cocaine comes in 4 and 10% solutions and may be administered on cotton applicators, nasal packing, or sprayed directly onto the mucosal surface. It is a very powerful vasoconstrictor. It reduces bleeding and it shrinks the mucous membranes. Dosages are carefully calculated to the patient's age and their physical condition. Adverse effects are seen in the central nervous system, usually including excitement, depression, and the respiratory arrest. Lidocaine and topical application of neosynephrine or Afrin are most commonly used now for this reason rather than cocaine. We do need to make sure when using cocaine, though, to remember that it is a controlled substance and should never be left unattended in the OR. Any unused must be returned to the pharmacy or destroyed with at least 2 witnesses. All right, moving on to benzocaine and tetracaine. Benzocaine, 14% is contained in lidocaine spray. It's a topical agent with rapid onset, and the duration is about 30 to 60 minutes. And it's used usually with bronchoscopy or a fiber optic intubation if our patient has an incredibly difficult airway and it is hard to see to get them tubed. We will sometimes use a fiber optic camera that is flexible and can go down into the back of their throat and into the larynx so we can visualize where we're going. And then we have tetracaine, otherwise known as pontocaine. This is very potent and it's very long acting. It is a 0.5% solution that's used before cataract surgery or spinal anesthesia because it provides rapid onset with excellent motor and sensory blocks, and the duration is usually 90 to 120 minutes. Okay, moving into the aminoamides. These are most common the most common used in surgery are lidocaine, bupivacaine, ropivacaine, and mepivacaine, which is much less common. So a key factor to remember, an easy way to remember our local agents, all of the local anesthetics are going to end in that cane. They will always have C-A-I-N-E at the end, and that indicates that it is a local anesthetic. Okay, all except for ropivacaine can be combined with diluted epi, usually 1 to 100,000 or 1 to 200,000. And also most except ropivacaine cause vasodilation, which can speed up the absorption. So epi, as we know, is a very powerful vasoconstrictor. When it's combined with local, it causes a local vasoconstriction, which slows the absorption of the local. That keeps the effect of the local at the surgical site longer because we are constricting those vessels that is not going to spread out as fast. And always remember, once again, straight epi should never be injected. Local with epi should never be used in the fingers, toes, tip of the nose, or the penis because we do not want those vessels further constricted. There is already limited blood supply to those areas. Okay, let's go over these individually here. Lidocaine, otherwise known as xylocaine, is the most common local anesthetic agent that is in use today. It is fast acting, it's rapidly metabolized. The duration for its effects are usually 30 to 60 minutes, and if epi is added, that increases it to 2 to 3 hours. It's available for injection in 0.5, 1, 1.5, and 2% with or without epi. A topical 4% solution for nasal and oral mucosal applications. And it's also available in a 2% jelly called a Eurojet. That is opened sterilely in the sterile field. It comes in a sterile pre-filled syringe. And that's used for urethral application during cystoscopies. All right, bupivacaine is also known as marcaine or sensorcaine. It's approximately 4 times more potent than lidocaine and has a duration of 3 to 7 hours. It's available in solutions of 0.25, 0.5, and 0.75% with and without epi. The duration is not extended with the addition of epi, but it will still limit the vascular uptake. Okay, 0.25% is often used at the end of a procedure to provide post-op analgesia. Remember, that is pain relief. The most common procedures for this use are inguinal hernia and lap cholecysts. It binds to cardiac muscle. The chief adverse effect, in fact, is cardiotoxicity, and it is contraindicated for IV regional anesthesia because of that cardiotoxicity. We do not want that going directly into the blood system. Okay, next we have ropivacaine, also known as neuropin. This is similar in duration to bupivacaine, but with a lot less cardiotoxicity. It's available in 0.2, 0.5, 0.75, and 1% solutions. It's packaged in vials and plastic ampules of 10, 20, and 30 milliliters. It also comes in something called a sterile pack, which is available in 10 and 20 milliliters, and that is for delivery straight to the sterile field. All right, mepivacaine, also known as carbocaine or polocaine. These are similar in potency and duration as lidocaine. They are available in 1, 1.5, 2, and 3% solutions, also with or without epi. They are used less often as there's no significant advantage over lidocaine, which is often more readily available. That is why we are using lidocaine most commonly. And if you see table 14.1 on page 194, that will give you an excellent idea of the local agent comparisons. And remember, as a surgical technologist, it is vital that you keep track of the amounts of local anesthetics used from the back table. The purpose of that is to avoid any type of toxicity and adverse reactions. So we're always wanting to keep track of our locals. All right, regional anesthesia is a technique used to accomplish both sensory and motor block to an entire region of the body. It blocks the nerves and the groups of nerves known as a plexus. It can affect sympathetic sensory and motor nerve supply, meaning that the anesthetized limb will be immobile as well as numb. And this is most commonly used ones are spinals and epidurals. All right, so we're going to talk a little bit here, spend a little bit of time on spinal anesthesia. Excuse me. Agents are injected through the duramater into the subarachnoid space and this cerebral spinal fluid in the lumbar spine. This is called an intrathecal route. It is usually performed at about L3, L4 of the lumbar spine. And this anesthetizes the entire lower body. Patients may be may lay laterally with their knees curled to their chest, or if they're unable to be in that position, they can be in a sitting hunched position for administration, meaning that they'll sit on the side of the bed or a table. Normally, we will put a pillow across their lap and tell them to kind of lean over and hug that pillow to really curve out that spine. It makes it a lot easier to get that needle in between the lumbar vertebrae. Okay, the skin around the injection site is prepped and a small drape is placed to kind of facilitate a small sterile field. Local anesthetic is injected into the skin before the placement of the spinal needle. And then once we have the spinal needle correctly placed, we will check for a drop of CSF. You will see CSF kind of leak back from that spinal needle, and that lets us know that it is in the correct position. It's got a very kind of clear look to it. Okay, once that needle is in position, a syringe is filled with local anesthetic. It's attached to the spinal needle. CSF is going to be gently aspirated one more time to confirm location, and then the local is administered. Okay, levels of anesthesia is verified using either an alcohol wipe or the pinprick method. An alcohol wipe, if it's on non-anesthetized region, it's going to feel cold. If the region has been anesthetized, it's going to feel warm or they won't feel it at all. And same with the pinprick. We will lightly poke them. And can you feel this? Can you feel this? Can you feel this? As we get lower and lower down the limb until we can verify where they're no longer feeling that poke. Okay, it is quicker to administer these than an epidural, and it doesn't provide a more intense block. If continuous spinal anesthesia is needed, a small catheter may be placed for repeated dosing. The most common locals used include tetracaine, bupivacaine, and ropivacaine. And this is used for procedures of the lower abdomen, perineum, or extremities. Now, there are some side effects that can occur with spinal anesthesia. One of them is a drop in blood pressure, and that is because of vasodilation. There are also post-dural puncture headaches, or the PDPH. You may also hear them called a spinal headache. These, in severe cases, can be treated with a blood patch, which is a small injection of about 20 milliliters of the patient's own blood that they will put in at the original site. Otherwise, it is usually laying supine flat on their back, and usually for about 12 to 24 hours till those subdue. All right, moving on to epidural anesthesia. With epidural, the anesthetic agent is injected into the space surrounding the duramater using either a single injection or a catheter that can be placed and left for continuous dosing. The positioning, prepping, and draping are identical to that of doing a spinal. Correct placement for these, though, is verified when CSF does not enter the syringe, because remember, with an epidural, we are not going that deep. We are only going into the dural space, not the subarachnoid. We'll do a test dose of the agent, followed by subsequent doses over a 1 to 3 minute period. And the common agents for this include lidocaine, bupivacaine, and ropivacaine. Dilute epi may be added to prolong the duration, and small doses of opioids will sometimes be added as well for post-op analgesia. Right. Epidurals are used to relieve pain of labor and vaginal delivery, as well as for cesarean sections. Bupivacaine is the local of choice for these, usually at 1/4 or 0.5%. There are some advantages over spinal anesthesia versus the epidurals. Epidurals have a reduced risk of hypotension. There are less incidences recorded of those post-headaches. Administration can be done higher than L3, L4. For example, we can go as high as T3 to T5 in the thoracic vertebrae. And the onset is slower, but the duration is usually longer. These are ideal when the operation time is variable or extended, and it can be extended post-op analgesia is required as well. Okay, and then just a little bit short on the caudal blocks. This is also a type of epidural block that is injected into the sacral canal right there by our tailbones. It's most often used with general anesthesia for urologic and lower extremity procedures in children for post-op pain management. And rarely, but sometimes it's used for vaginal childbirth. These are rare. Usually we're using the spinal or the epidurals. And it should be noted, if we are doing a spinal or an epidural on a pediatric patient, those are usually placed after general anesthesia has been administered. All right, moving on to some peripheral nerve blocks, or PNBs. These are also known as extremity blocks. You'll hear that more often. These are done pre-op. So pre-op preparation includes pre-medicating with those anti-anxiety meds and some pain relievers to lessen the discomfort during blocks. Precise location of the nerve to be blocked is vital, so we're using ultrasound to place these. Once the needle is verified, or the location, of the needle is verified, a syringe is used to gently aspirate to make sure that we're not in a blood vessel. A test dose is administered, followed by small subsequent doses until all of the agent is administered. And the common agents used for these are lidocaine, bupivacaine, and ropivacaine. Okay, the brachial plexus block is used for procedures of the hand, forearm, or elbow. These may be done interscalene, supraclavicular, intraclavicular, or axillary, which is the most common. Okay, approximately 30 to 40 milliliters of agent is injected into the nerves that are adjacent to the axillary artery, and this makes the entire arm go numb and immobile. One primary disadvantage of these is that they do take time to take effect. Therefore, they're administered in the pre-op area. However, they may delay surgery a bit if we're waiting for that block to take effect. So it's always a good idea to let your surgeons know what's going on and keep them appraised of the situations. Okay, then we have the intravenous regional anesthesia, or IVRAs, aka the beer block. These are faster and easier than brachial plexus blocks, and the onset is immediate. These are used for procedures on the upper and lower distal extremities, but most commonly they're used for procedures of the wrist and hands. Lidocaine is the most common agent without epi, because IVRA duration is based on tourniquet time rather than the agent's duration, so we are not using epi with these. So for example, in a hand procedure, the tourniquet's placed around the patient's arm. An IV catheter has usually been placed pre-op in the patient's hand on the dorsal side in a vein. Once the patient is into the OR, the blood is exsanguinated from the arm, so we raise it and wrap it with an S-mark to get that blood out. The tourniquet is then inflated, and about 40 to 50 mL of the agent is injected into that catheter. The catheter is then removed, and we can prep the hand and proceed with our procedure. Once the procedure is finished, the tourniquet is released very slowly and intermittently so that we can avoid rapid infusion into systemic circulation with all of that local that has been piled right there. And finally, we have the retrobulbar blocks. If you remember, we talked about these a bit in the eye chapter. These are injected behind the eye into the muscle cone to block the branches of the oculomotor nerve. These are used for procedures requiring a motionless, anesthetized eye. Typical injections made up of equal parts of 0.5 to 0.75 bupivacaine and 2% lidocaine with 150 units of hyaluronase. The sedative may be given to reduce the patient discomfort while doing this. I know I would prefer one. And the peribulbar blocks are actually more commonly used. They do take more anesthetic agent and they have a slower onset of action, but they are more comfortable and a little less anxiety provoking than those retrobulbar blocks. All right, guys, that brings us to the end of chapter 14. Any questions, please take note of them and we will go over them in class, and I will see you guys in just a little bit.